Hello everyone, my name is Tiara Brooks, and here at School-Based Health Alliance, we would like to thank everyone for attending today's webinar titled, Patient-Centered Medical Home Recognition is Possible. But before we begin, we have a few housekeeping items. First, please help us with our attendance count. If you are viewing as a group, please go to the chat window in the question box and type in the name of the person that is registered and the total number of additional people in the room. For example, Tammy Jones +3. This will help us with our final attendance count. Also, all attendees are in listen-only mode. However, we want to hear your questions. To ask a question at any point during the webinar, please use the question box located in your GoToWebinar control window. We will address all questions following the presentation. This webinar is being recorded and will be archived on our website in 3 to 5 business days. Please also visit School-Based Health Alliance for additional archived webinars. The School-Based Health Alliance works to improve the health of children and youth by advancing and advocating for school-based health care. When health and education come together, great things happen. At the end of this webinar, attendees will be asked to complete evaluation poll questions. Please let us know how we are doing. Your feedback is vital in helping us craft presentations such as this webinar to meet your needs. Now I would like to introduce our presenters. Dr. Maureen Daly is a SBHC and clinical consultant and provides support as an expert faculty for the School-Based Health Alliance National Quality Initiative Performance Measures. Dr. Richard Lynn Cook is an assistant professor in the Department of Family and Community Medicine at Baylor College of Medicine and serves on the board of the Children's Health Fund and is involved in the implementation of the Patient-Centered Medical Home Initiative, the Pediatric Committee, and the Epic Documentation Redesign Initiative. Margie Rogers is the Director of Primary Health Care at the Montefiore School Health Program. As chair of the New York School-Based Health Alliance from 2013-14, she led the Patient-Centered School-Based Healthcare Project to draft and pilot PCMH standards designed for SBHC. Janelle Dunn joined True Health in 2012 as a center manager for the Lake Underhill Center and is most recently served as the organization's Director of Operations. And Zena Montella joined True Health in 2009 and currently oversees the Nursing, Lab, and Case Management departments. She is experienced with initial and follow-up surveys for the Accreditation Association for Ambulatory Health Care's PCMH. Thank you, everyone. I will now turn it over to our first presenter, Dr. Maureen Daly.
Thanks. Welcome, everyone, and thanks for joining us today. We have 3 objectives for the webinar. First objective is to learn about the comparison of the various patient-centered medical home recognition processes. The second is to be able to identify the benefits and challenges of the various PCMH recognition models. And lastly, to describe the patient-centered school-based healthcare recognition model that has been designed specifically for school-based health centers. So a handful of national healthcare organizations have developed standards and assessment tools for formal patient-centered medical home or PCMH recognition. Some call it certification, others call it accreditation. These first 3 organizations listed are the most common. The first, the Accreditation Association for Ambulatory Health Care, or AAAHC. The second, National Committee for Quality Assurance, or NCQA. And the third is Joint Commission. The purpose of going through the recognition process and using these assessment tools is to evaluate the extent to which your practice has integrated medical home principles. The tools really focus attention on aspects of primary care that are thought to improve quality and reduce costs. Ms. Janelle Dunn and Ms. Dina Montella will be sharing their experience with the AAAHC patient-centered medical home model, and Dr. Richard Lynn Cook's going to talk about NCQA's model. In addition to these 3 nationally recognized models, a 4th model has been developed specifically by for school-based health centers, and it's called patient-centered school-based healthcare. And Dr. Margie Rogers will be talking about this model later in the hour. I've also listed state-specific standards here. Some state Medicaid agencies have developed their own standards for patient-centered medical home. Here in Colorado, for example, our Medicaid agency has their own standards, 9 standards that school-based health centers and other primary practices can be certified in. Thanks. Next slide.
Okay, we now have our poll question.
So our first poll question, we want to know if your school-based health center is recognized or certified as a patient-centered medical home. You can click one or all that apply.
Okay, we'll give you a few more seconds.
Wow, okay, so this is going to be a good webinar then, because we have experts who've gone through the various models and are going to be able to share about them shortly. So in terms of comparing the various recognition models, they do vary in several aspects, including cost, the cost to be certified, in the scope, and by this I mean some patient-centered medical home models certify an individual practice, while others certify the entire organization that may be composed of several individual practices. Eligibility criteria vary. What the process is, for some, like NCQA, it's an online application. For others, it can include an on-site visit to the practice. Another aspect is whether ambulatory care accreditation is required before receiving patient-centered medical home recognition or not. And I just want to point out here, ambulatory care accreditation is different than patient-centered medical home recognition. Ambulatory healthcare accreditation is an involved process where quality and safety are assessed through an on-site survey. And many of you may be familiar with Joint Commission accreditation, but patient-centered medical home recognition, which is what we're talking about today, although it's rigorous too, it specifically assesses primary care practices against standards of patient-centered medical home. In addition, some other aspects, the level of recognition can vary, and the cycle. And by that I mean how long the recognition is good for, a year, 3 years, etc. Next slide. So the Alliance now has an entire section on patient-centered medical home and school-based health centers on their website. And this is a screenshot of the website. If you click on, and you can kind of see it at the bottom there on the right, deciding on a PCMH recognition program, you will find a comparison chart of the various patient-centered medical home models. So a few questions to ask yourself if you are considering pursuing patient-centered medical home certification. The first question, and a very important one, is to ask your staff, are they willing to commit to this process? It takes a team to get the work done, and so your school-based health center staff really need to be on board to be successful. Second question, is your electronic health record, has it been functioning for at least 6 months? As you will learn shortly, much of the work involves data extraction and generating reports and using EHR functionality. So you probably don't want to launch into this process if you're just beginning with a new EHR. Third, is the recognition a requirement of payers, regulatory agencies, or managed care organizations in your state? And if so, which model do they require? Has your medical sponsor already pursued patient-centered medical home recognition for their community clinics? This may seem like an odd question, But a very important question to ask. Some school-based health centers have found out as they begin to look into this that the other community clinics within their organization have already gone through patient-centered medical home certification. Lastly, what is the cost versus benefit? Will the school-based health center qualify for higher reimbursement or enhanced payments with recognition? This would serve as a carrot for undertaking this process. I want to turn it over now to Ms. Janelle Dunn and Ms. Dina Matella, who are going to talk about their experience with the AAA-HC PCMH certification.
Thank you, Maureen. Good afternoon, everyone. Thank you for attending this presentation. Hopefully, the information shared will empower you to be successful in your decision to seek patient-centered medical home certification. My name is Janelle Dunn, and I am the Chief Operations Officer for True Health. And I also have with me Dina Mantella, who is our Director of Nursing. Our organization is a federally qualified health center, and for 40 years, we have provided primary care to the residents of Central Florida. We have 8 locations throughout Orange and Seminole counties, one of which is on the campus of a local elementary school. We underwent our initial patient-centered medical home survey with AAA-HC in 2012 and was awarded full accreditation, which is 3 years. In 2015, we were recertified with full accreditation and are scheduled for a third site review in 2018. Now we have a poll question. Our organization is working through patient-centered medical home recognition in, it's either the next 60 days, 90 days, within the next year, or we are just reviewing our options.
Okay, thank you, everyone.
Great information, thank you. The Accreditation Association of Ambulatory Healthcare, better known as AAA-HC, has a comprehensive manual that outlines their standards for accreditation as well as for patient-centered medical home. Next slide. According to AAA-HC, within the patient-centered medical home, patients are empowered to be responsible for their own health care. As used in these standards, a medical home is the primary point of care for the patient. In other words, the medical home should act as a hub for the patient, directing the patient in their health care and teaching them how to manage their own health. Next slide. So from an operations perspective, you want to pay special attention to your policies and procedures, methods of staff education, and cleanliness and overall safety of your facility. Policies and procedures should be reviewed and modified as necessary. If you have a board of directors, your board should approve the policies at least every 2 years. Your policies should be concise and guide the reader or user to the appropriate resources. For example, if your policy is created due to HRSA mandates, then the resource should reference that section of the HRSA manual. Procedures should provide clear guidelines that assist the reader in carrying out an activity. Policies and procedures should be easily accessible by employees and archived once they are out of date or duplicated. Staff education. During a site audit, a reviewer may ask any of your employees about your processes. And so because of this, you want to ensure that all team members are educated at least on the basics of your operations. For example, in our case, we are a federally qualified health center, and we offer a slide fee discount for our uninsured patients. Therefore, we educated all of our employees about what documents should be presented by patients to qualify for the sliding fee scale. You'll also want to ensure that your staff is knowledgeable about your organization's mission and vision. Facilities management. The auditor will take a walk throughout your site to inspect the cleanliness, safety, and overall appearance. They will also check your fire extinguishers, expiration dates, evacuation lights, and emergency lighting. Creating a monthly facilities checklist will ensure that your buildings are always audit ready and will serve as a reminder for your employees to conduct routine maintenance and repairs. In addition to the monthly checklist, prepare your staff with general company knowledge by creating a one-sheet frequently asked questions reference guide. For example, our guide provided reminders about our vision, mission statement, how long our organization was established, information about our board of directors. We also included information about how many exam rooms their building had, all of our locations addressed, where our OSHA, STS manual, and our policies and procedures manuals were stored, so that they didn't fumble when it was time to answer the question, that they would automatically be able to point the auditor in the right direction. Next slide, please. The clinical component of AAAHC is extremely comprehensive. They like to see procedures, protocols, both written and in action. During an inspection of the facility, they will look at calibration dates on clinical equipment, sharps containers, and emergency kits and crash carts. We have a poll question. Our policies are regularly reviewed and updated biannually, yes or no?
Thank you, everyone.
Great. As Janelle discussed, policies and procedures are a big requirement for AAAHC. The AAAHC manual identifies specific policies and procedures that are required for all aspects of the clinical department, including infection control, radiology, laboratory, and clinical workflows. Ensuring that your organization has these policies and procedures outlined for staff to access at any time is a tremendous component of accreditation and patient-centered medical home. Clinical facility checklist. These are also encouraged to ensure that monitoring of the clinical units happen. For example, emergency kits or crash carts should be inspected monthly for expired supplies. The stock medication log should be reviewed monthly to ensure there are no missing doses. If you have a manager or a lead at a location, having a checklist ensures they accomplish what is needed at the appropriate time frame. Skills assessment. Reviewers will ask what type of training is done for employees, especially the clinical staff. However, if someone has been through orientation a few years ago, they want to know what are you doing to ensure their skills are up to date. Yearly skills assessments give managers the opportunity to ensure that specific clinical skills are being performed appropriately. For example, injections, placement of EKG leads, etc. Quality. AAAHC requires 2 quality studies a year. These studies can pertain to any subject area but should be in direct relation to the organization's clinical practices. For example, is it policy to foam in and foam out of every room? You can run a clinical study to give more information. AAAHC can also give guidance on suggested studies or content areas. Documentation. AAAHC PCMH standards include using evidence-based guidelines and performance measures in practice and documentation. Your chief medical officer or medical director should have approved clinical guidelines that are readily available for the medical team to review to assist in standards of care. A clinical guideline is something as clear as the CDC's vaccination schedule for children and adolescents. We have another poll question. How many providers does your practice employ? 0 to 10, 10 to 20, 20 to 30, or more than 30?
Great. Thank you, everyone. I'll now share the results.
Next slide. Staff buy-in. For us, we included the staff in all conversation of accreditation and PCMH from day one, helping them understand what we were doing and why, keeping them updated and involved, helped get them on board and open to any policy and procedure changes. Allowing them to ask questions helped ease their own fears and made them comfortable with the process. It's very important to explain to your team why you're seeking accreditation. And I think that the communication methods should be varying. I think that you should include email, face-to-face meetings, and also written materials so that they can use as a reference. You want to communicate how it will impact your employees and your patients. For example, achieving PCMH status enables you to recognize it on grant applications. It also is impactful during your insurance reimbursements now that every organization is becoming quality driven. And it also gives your patients peace of mind, which is valuable. You want to prepare your staff on what to expect during the survey. Doing mock surveys at the site, asking questions that a reviewer might ask, helps them get prepared and less nervous for when the real site survey begins. And clearly outlining the expectations of each department is extremely vital. During your site audit, the auditors are going to review the human resources records. They're going to review the billing processes and documentation. They're going to review your clinical processes, your sharps, how your biohazards are maintained and where they're stored. They're also going to take a deep look into your operations, looking at the documents that you require for registration and ensuring that the forms are completed properly, or at least to what your processes are established as in your procedures. They will also be taking a look at your facilities overall, again, for safety, cleanliness. So it's very important for each of these departments to be included in these conversations. And at the end of the day, explaining to the staff what we're trying to do by becoming a patient-centered medical home. We want to be the focal point for the patient. So while for us, we are primary care, if the patients need a specialist, we want to guide them in that direction. We're a community health center. We have a lot of patients that just do not understand their health care or what they need to do next. As a patient-centered medical home, we outline the path for them. We help show them the way. And we include them as a part of the process to keep it patient-centered. Thank you. Next slide.
Good afternoon, everyone. My name is Richard Lynn Cook. I'm a physician in internal medicine and pediatrics, and I work for Baylor College of Medicine. The Harris Health System, which is the largest public health safety net organization in the state of Texas, about the fourth largest in the country, has a system of school-based clinics, of which I'm the medical director. And in my brief amount of time, hopefully less than 10 minutes, because I want to leave time for a lot of questions, I just wanted to give an overview of what the standards of the patient-centered medical home are. My Margie Rogers, who's going to follow me, can get a little bit more specific about the standards for school-based health, but I will probably have some overlap with her. We actually got our most recent recertification with the 2014 standards, and they have been recently updated to now the 2017 standards. And this was in response to requests by multiple stakeholders to NCQA to cut back the process, the paperwork, the complexity, to simplify the reporting. and also to keep consistent with recent changes in federal law, which are pushing for more value-based healthcare. So if you are somewhat familiar with the previous standards, I'm not going to assume that you are, and I'll leave some time to ask questions about it. But there are lots of standards and elements and then factors within those elements that are very daunting. The 2014 document is 70 pages long, and each page has weeks and months worth of work that could actually support what NCQA is requesting that you do. The good news is that if you have an established primary care setting, a FQHC, community-based health center, you're probably doing most of what you need to be considered a patient-centered medical home, but you may not have the mechanism to actually document and detail what you're doing, and that's essentially what NCQA is asking for, and therein lied the challenges for us. To be very brief, the 2017 standards are very similar to the 2014. However, in response to all the requests to make the process a little bit easier, NCQA has actually made it easier by I'll use the example of the accreditation bureaus. So, the Joint Commission is what the Harris Health System used to use, and this is different from the what will be spoken about coming up about Joint Commission certification. This is the so-called JACO visit, right? The site visit where everyone was running around and hoping that they weren't going to get cited by JACO. Well, the Harris Health switched to an organization called Det Norske Veritas, and essentially what the big change was that we set our own policies that were to be evaluated, and then we essentially were evaluated on how we met our own established guidelines. And that is essentially what the change is between 2014 and 2017. It's less prescriptive by NCQA. You evaluate your organization, you determine what you're capable of doing in a certain amount of time, and then NCQA will assist you in achieving those goals towards being a patient-centered medical home. I think that's a great idea. I remember going through this process now. This has been 3 successive recertifications, and it's actually gotten easier each successive time. Now, I will say this. I represent a very large organization that had quite a bit of this infrastructure already in place. We're using the EPIC electronic medical record since 2007, which was long before a lot of other similarly large organizations. The meaningful use CMS program was already in place, so we were already evaluating our electronic health record to make sure that it was in compliance with meaningful use. So I'm not sure. I wish I had a poll question right now to assess how large your organization is and how much of this you have in place. But as Dr. Daly had said in the beginning, having an EHR is quite essential to being able to pull this off. And if you don't have an electronic medical record and you're still interested in doing this, I may have some pointers for you towards the end. But very briefly, the standards are patient-centered access, team-based care, population health management, care management and support, care coordination, care transitions, and performance measurement and quality improvement. Now, if you're going to use NCQA, essentially you have to then focus on the 2017 standards, and I've put the ones that are similar to the previous 2014 standards they're right next to each other. So patient-centered access and continuity, team-based care and practice continuity, knowing and managing your patients is what population health, what it used to be population health, care management and support, care coordination, and performance measurement. Now, let me just give some brief examples of what falls underneath these categories, and then I'll pass it on to Margie. So patient-centered access and continuity. So, for example, is your organization able to provide same-day appointments? Do you have an electronic medical record in place where you can actually give clinical advice either through the EMR, through something like MyChart or MyHealth? Do your patients have electronic access to their providers? Those requirements, that's just one example. There are multiple other requirements, but essentially the standard means are you able to accommodate your patients where they are? Some of our school-based clinics are located in very poor sections of Houston, and you know, our patients are able to walk right in and get a same-day appointment. And in pediatrics, obviously, that's especially important. But you know, are your patients able to call the call center and get an appointment? Does your template actually reflect that you're able to do this? And that's what NCQA would be asking for. Show us an example of your template. How many slots are reserved for same-day appointments? So if we move on to team-based care, so examples of team-based care, I put down, you know, how is your practice team defined? You know, do you have nurse practitioners? Do you have LVNs, CMAs, physicians? And what are their individual responsibilities? So NCQA would likes to know what the team is comprised of and the duties of the team. Other examples are, how about care across different settings? We have in our electronic medical record access to medical records from other hospitals. So, for example, Houston is obviously has a very large medical center, I believe the largest in the world, and so our patients do have options. So, if they've been seen at University of Texas or Texas Children's, do we have access to their records? And we do through something called Care Everywhere, which is an Epic EMR product. And if you don't have an EMR, you need to have a process in place whereby you can obtain information from other providers, because your patients may get care across other settings. And the 2017 standards essentially expand upon that. I didn't detect any major changes between 2014 and 2017. Population health, I won't spend too much time with this. We all collect data on our patients, and an EHR helps you to auto-generate reports and actually auto-collect data. So your vital signs should include a BMI, and it should be auto-calculated. I will say that some of these standards can be what's called a corporate attestation, meaning you don't necessarily have to send detailed information to NCQA. You know, you can attest that your organization collects, you know, vital signs, BMI, you know, various things, race, age. These are, you know, nuts and bolts vital signs and demographic data. But then also things that are a little bit more you know, detailed, like are you following patients for chronic diseases? What chronic diseases you know, did you select? And in our case, we selected kids who are obese, who have lab abnormalities. We selected children who might be overdue for their well childs, and we selected children with mental health disorders. Well, we selected those. Now, can we auto-generate reports on those patients? And an example of a report is a child who has missed their one-year visit by, you know, more than 3 months. We get a list of those patients, and then we have staff that are actually calling them to come back in. So in care management and support, again, that's somewhat similar. You know, population health. It's identifying patients who need additional services and then getting them plugged into those services. And an example is, you know, HPV vaccine for adolescents. You know, we've had a big problem with getting our adolescents that third vaccine. It's actually a nationwide issue. With the 2-dose HPV-9, that's a little bit easier. But you know, how were we identifying those patients, and how were we getting them back in, and how did we use our EHR to actually accomplish that? And then individualized care plans. the 2014 to 2017 standards really stress that providers come up with a care plan that's not just a generic, run-of-the-mill care plan that you print out for everyone, but something specific. So, for example, you have an obese child who likes to drink Kool-Aid. Well, you've spoken with the parents, you've spoken with the child, and your plan is to reduce the amount of sugary drinks, and then you follow up on that. And as long as that's been documented, then that would be passing. So again, we did this before we had EMRs. We wrote it in our paper charts that this was our plan for our patients. If some of you listening are nurse practitioners, you spent probably more time than the physicians did counseling patients. It's just a matter of being able to document this. So I won't spend too much time on care coordination and also performance measurement. The care coordination and care transitions I somewhat discussed with team-based care, but I will say that one example of this is referral tracking. If you've sent your patient out somewhere for subspecialty care, how are you able to track that? That's extremely important. Transitioning pediatric patients to adult centers is also something that falls under both the team-based care and the care coordination. And then the performance measurement is essentially all that you are doing in standards 1 through 5 for either 2014 or 2017. How are you measuring it? What's your scorecard? What is the standard that now you've set for yourself to achieve, and how have you achieved it? And then how can NCQA help you achieve that? Can you go to the next slide? I think I don't have a next slide actually. So I'm going to let Margie talk a little bit more about the school-based specific standards. And again, any more specific questions about any of the standards or the difference between 2014 and 2017, I'll be very happy to answer towards the end. Thank you.
Thank you, Richard. Hi, I'm Margie Rogers, and I am the Director of Primary Health Care for the Montefiore School Health Program, and got involved in this project through my role in the New York State School-Based Health Alliance. So I want to actually start with a poll. We've looked at, thank you, Richard, for going through the PCMH standards, and the next picture you're going to see is the poll questions. And what I'd like to know is, have you encountered any of these challenges in the PCMH process? Check all that apply. Or if you haven't been through the process yet, do you anticipate this being a problem or a challenge for you in the PCMH process? Okay, great. Thank you. All right, so what I want to do is have you kind of look at this for a minute and see, some of you may not be aware of what the PCMH process is clearly enough to know what the barriers might be, but on to the next slide. And when we looked at some of these barriers, we realized that some of the things were very difficult for school-based health centers to overcome. And some of these are what NCQA calls the eligibility requirements. And one of those is that we can demonstrate that we are the primary care provider for 75% of our patients. And that's what makes us a medical home, is that we're that home. As many of you know, school-based health works a little bit differently, that we see kids and we often are the principal provider of care. We provide the most care. They with their feet, they choose us as their primary providers, but we're not necessarily the primary care provider of record. And so that created an issue that we felt we needed to address, along with many other more minor things, I would say. So we gathered together, we created some standards that we thought were very true to school-based healthcare, both our strengths and the challenges that we had with the PCMH process. And we piloted these standards in 2 states, in New York and Connecticut. In October, November, we submitted them to NCQA as a proposal to have them accept them. Now, that was in 2016, so we were working off of the 2014. We modeled them very closely on the 2014 standards. Since then, just a few weeks ago, the 2017 standards came out, and we are in the process now of aligning the school-based health center challenges and strengths with the 2017 standards. And so what I'd like to do in the next few slides is show you a little bit of how we've done that. The plan is actually for these standards to go to the NCQA board in June, and if they adopt them, then we would be able to start applying for NCQA school health recognition beginning in July. So here's the crosswalk. We'll go on to the next slide. The first thank you. That we're good. The challenge of being the PCP. So what we proposed and is being written, and I will say that this is not set in stone. I was on the phone until 6 o'clock last night working with NCQA over some details of how we're going to be defining all of these things. So this is what we have now, but what comes out in June may be slightly different. But the idea is that we provide in school health 3 levels of care. We provide comprehensive primary care where we've been identified as the primary care provider by the patient, by the family, or de facto they do not have any other primary care provider and we are it. Coordinated primary care where we are working closely with the patient on certain areas where they're not accessing their primary care provider or their other medical home. And we have become the primary care provider, but they do have an identified care provider, and that would make them coordinated care. We need to be coordinating with their provider to provide that care, but we are a medical home for that patient. And then minimal primary care, episodic care, the kids that come in once in a while, but are well connected elsewhere. Now, the challenge for us will be that we will need to have a system to identify what level of care we're providing, and that's something that we will be working on as the standards come in. All right, next slide. Okay, team-based care and practice organization. One of the challenges for school-based health centers is that we have a very small team. So when we talk about medical champion or physician champion, clinician lead, it's very difficult when there's only one clinician in the site. They have to both be the person who's implementing and the person who's leading. So what we have worked out is that the clinician lead has to be embedded at the site. So the practitioner at the site will be the clinician lead, but an administrative lead can be shared across sites, and a medical director can be the actual clinician lead for the whole process, with each site leading themselves. For behavioral health manager, it can be the behavioral health provider, as long as that person is working with the case management. Excuse me. All right, next slide. Next slide.
I'm sorry, I think it's, oh, okay. It's a freeze on the computer. I'm sorry, everyone.
Okay, great. So I just, for when you go back to look at these slides, the bolded ones are ones that we are adding in as new, and the others are ones that are accommodations for that we're making for school health. So an elective credit for the PCMH is engaging with the community, and we felt that this needed to be moved into the core section, that engaging with the school as a school-based health center should be core credit, that if you're not engaged with your school, you shouldn't be calling yourself a school-based health center. So we moved that from elective into the core credit, and in the elective credits, we added looking at the school population as population for population health. So not just those kids who are enrolled in regular users in the health center, but the school in general, looking at what their health needs are. That for elective credit, we are doing that in many of our sites. A reproductive health needs assessment is something that many sites are doing. School classroom-based or school-wide resources and case conferencing. case conferencing with the patient's PCP is something that we have, again, moved into the core. And what we discussed last night is that we're actually going to be taking some of the connected care NCQA standards and adding those into the school-based health center standards, so that the school-based health center standards end up being kind of a hybrid between PCMH and connected care, because there are those patients for whom we are not the primary provider, but we are providing care, and then we need to be able to show that we're connecting with the primary care provider and coordinating that care across those, across the healthcare neighborhood. Another issue that had been a challenge for many people was that they're not open during the summer, or that they don't have extended hours. The extended hours we kind of were able to eliminate because most school-based health centers are open before 9, and if you're open before 9, that's considered extended hours. So the real issue was the after-hours care in summers, and what we have done is, as an eligibility requirement, again, like the primary care provider status, you have to have in place a process for which you inform your patients and you coordinate care with your sponsoring organization or with another organization, so that there is a clear care provided for those patients over the summer, over school holidays, and after hours. And that can be linkage with your sponsoring organization. So you don't have to be open 12 months for the school-based health standards. Next. Okay, for care management, again, a challenge that we often have is that students seek care without the parent present, so we're often on the phone and we're working with them. We wanted to make sure that that was recognized, that how we engage with parents would be acceptable for these standards, as long as we're doing it well. And also that some of our care management, I think Dr. Lynn mentioned that you might be working with kids who are obese, kids who need their HPV vaccine, a lot of different things that we might be doing for care management. We may also include kids for behavioral health and kids who've been referred by the school personnel in this category. And then for care coordination and care transitions, the school health model is different, and for our basic definition of a school-based health center for these standards, we actually worked this out with the state leadership for the School-Based Health Alliance. We felt that the baseline for these standards should be having full-time medical on-site and an integrated co-located behavioral health component. So our model is slightly different from the patient-centered medical home, which tends to have everything going through and through the physician or through the medical provider. And for this, we really wanted to show that when we're providing the primary care, it's a team approach, which is very consistent with the patient-centered medical home, and that we are communicating and coordinating with the patient's primary care provider, as I mentioned before, co-located integrated behavioral health. And one of the things that we will have to be working on is how the hospitals identify our patients if we're not listed as the primary care provider, so that we can assist in following our patients through hospital admissions and ED. And then for transitions, just that last one was about transitioning out of the school, is also one of the transitions that we would be looking at. So performance management and quality improvement, just a couple of things. This is pretty basic CQI for the most part, but what we did recommend in the standards is that the School-Based Health Alliance core quality measures be used by school-based health centers. There's a couple of advantages to that. One is that if you get elective credit if the indicators are benchmarked, and what we'd really like is to see them benchmarked against practices that are similar to ours. And so once the School-Based Health Alliance core quality measures have become more generally used, we will be able to benchmark ourselves against other school-based health centers. So we did recommend that, and that we use the School-Based Health Alliance Patient Experience Survey, which is still being piloted in on the state level, but we're hoping will come into general use in the very near future. Okay, so I think we have one more poll question. And this is asking you what benefits you'd like to see from PCMH recognition. This goes back to Maureen Daly's question at the beginning about what's in it for you. Why would you bother to go through this fairly arduous process? Even the school-based health center standards don't make the process easy. They make it possible, but they don't make it easy. So, and there you are, 100% saying higher standard of service quality. That's really what we're looking for, I think. Reimbursement would be great. National and recognition of the model is really important, but really creating a higher standard of service for our students is the bottom line. Okay, so I just want to do one summary slide and then we'll go into questions. For all of these, and I think this was a very nice flow with the AAAHC talking about really how you implement the standards with your staff. That really holds true across all of these different standards. And there are some things that you really have to do to be able to achieve medical home standards wherever, whatever path you decide to take. And that is to make sure that you have comprehensive written policies and procedures, that you have documented clinic workflows, that you maximize your electronic health functionality. And even if you have an electronic record, you may not have been accessing the data extraction and reporting, the bidirectional communication with PCPs, care plan templates, and some of the other tools that are available within them. And you may want to be working with your tech folks to figure out how to do that. For population management, you need to begin to think about how you're going to identify your empaneled patients. Who are you a primary care provider for? Who are you coordinating with the primary care provider with? What targeted services you want to do, what kind of proactive outreach you're doing, how you do point of care reminders, and that you have a really robust continuous quality improvement program. These hold true for all of the different patient-centered medical home processes. Okay, I think we're ready to move into questions.
Okay, thank you so much, Margie. Now, while everyone is answering their questions, I just want to do just a couple of announcements so we can give you a couple of minutes to answer your questions. Our members extend and support our work at School-Based Health Alliance. Trainings like this webinar would not be possible without support of our members. In addition, our members receive exclusive access to valuable program tools, timely publications, and networking opportunities. And we ask that you visit our website at sbhforall.org/membership for more information and to join. Also, as a member, you get a great discount to our 2017 National Convention, which will be in Long Beach, California this year, and from June 18th through the 21st. So we ask that everyone, if you can please join us, School-Based Health Alliance and California School-Based Health Alliance at our 2017 National School-Based Healthcare Convention. Now we'll take a moment to read off a few questions from our attendees. Our first question is, can you do NCQA accreditation if the SBHC closed during the summer?
Dr. Lynn Cook, do you want to take that one or do you want me to take it?
Well, I can start. I think it would be quite difficult to pass the standard of access if you're closed during the summer. My particular school-based clinics are actually open in the summer. They service both school-based clinics and community health centers. But Margie, I think if NCQA, if that process that you're working on, which is excellent by the way, would potentially address the summer hours, that might be a way to go. But as of right now, it would be quite difficult to achieve at least level 3 certification.
Yeah, that's my understanding as well, that it would not be possible to get NCQA PCMH recognition at this point in time. However, there are a couple of other options. One is the connected care standards, which you might be eligible for. And the other is if the school-based health center, or when, I like to say, the school-based health center standards are adopted later this spring, then that would also be an option.
Thank you so much. We have another question. It's kind of a two-part question. How are you integrating mental health care, and are you educating your staff on this population's health? Also, are you embracing the ACE study and its impact on overall health?
Well, I can start with the mental health portion of that question. So again, we're fortunate enough to have access to mental health at our other sites that our school-based clinics are affiliated with, and coming out of Texas, that's actually a big deal. We have some of the lowest rates of insured patients and mental health access in the country, but essentially it's integrated into everything that we do, but I think the real answer to that question is that we actually just have mental health providers. It's a priority for the Harris Health System to provide quality mental health for our pediatric patients. So if you are coming from a situation where you might not have that, then if you're looking at it with respect to being able to achieve PCMH recognition, you would have to put into place some means of having that available, whether it be through the school or having mental health behavioral therapy services that you can access. But yeah, again, maybe some of the other panelists can speak about the challenges that they have had, because I have not had too many challenges actually meeting that requirement and actually getting my patients in.
Yeah, the NCQA standards require behavioral health linkage, whether it's the straight PCMH or the school-based health center. In terms of ACEs, that would be a screening that would be honored in the knowing and managing your patients. And sorry, I just got interrupted. Let me leave it there and see if there's anything from AAAHC that they want to add.
For us, we do not have an internal component of behavioral health. However, we have community partners that we work with and refer out and send our patients to for the behavioral health component.
And I think that's the key. The assessment within your actual site is fairly simple, but if your organization itself doesn't have robust enough mental health services, you can partner with local FQHCs, and we are doing that as well here. The FQHCs are partnering with us, and we're partnering with all the other hospitals in Houston, as long as you have a process in place whereby you identify patients with mental health disorders, and you have the ability to refer them somewhere, you may not get the actual highest recognition, but if you can actually get them to a mental health provider within the community and document that, then then you should pretty much be okay.
Actually, with the 2017, there are no more levels. So you have to meet all of the core requirements, and then you have to meet a certain number of points in the elective. So with the 2017, there's no longer level 1, level 2, level 3.
Okay, thank you. And we're going to try to squeeze in one more question. My final question is, how can we know that the SBHC standards are adopted? Is there a newsletter that they can sign to?
I think we will make a big national announcement. I will be at the convention in June and hopefully have some word then. But yeah, definitely. John Schlitt has been part of the process. He's been participating in the conversations. So I expect that we will have a national announcement about it. And NCQA will be marketing them as well.
Okay, great. Thank you so much. That was our final questions, and we definitely like to thank our presenters. And now that we heard from our attendees, we do have a few questions for you. If you can please just take a few seconds just to answer a few poll questions for us. And our first question is, does this presentation meet your needs? Thank you, everyone. Our next question is, how well did this presentation meet your needs? Meet the stated objectives, I'm sorry. Okay, and how likely are you to apply this information in your organization? Thank you, and would you recommend this webinar to others? This is the final poll question. Okay, again, thank you so much to our presenters. We really appreciate you all for taking this time out for this webinar, and thank you to our attendees for attending today, and we hope that everyone have a marvelous day.